Welcome to the Healthy Skin Show with Jennifer Fugo, where we're flipping everything you've been told about your chronic skin issues upside down and connecting you with alternative solutions your dermatologist never told you about.
Welcome back to episode number 246 of the Healthy Skin Show. If you've ever wondered what type of testing a dermatologist might be able to do, and if they do testing at all, well, today's episode is going to answer that question for you because yes, dermatologists do run very specific types of tests to determine what type of diagnosis do you have, as well as are you sensitive to certain types of things in the environment, and lastly, is there some sort of skin infection going on? These tests are things that can be run in any dermatologist's office, and this is a great opportunity to break the differences between these tests down so that you know what to potentially ask for and to know whether a test that you had in the past would still be helpful if you end up with a flare and are wondering if, for example, you might have an infection. My guest today is Dr. Peter Leo. He is a show favorite. I know you guys are going to love this episode because he always gives us his best. And this episode is absolutely not going to disappoint. Before we dive in, I want to take a slight detour to share a review of the Healthy Skin Show from a listener. The listener's name is What Tracy Says. Tracy describes the show as the best resource for skin issues and shared that I feel so fortunate to have found Jen Fugo and this podcast. I've learned so much from listening to her and her amazing guests. She dives into each topic with enthusiasm and curiosity, getting at not just the what, but also the why. She's helped me to feel not only knowledgeable, but empowered and optimistic about resolving my issues. They say when the student is ready, the teacher will emerge, and Jen is an amazing teacher. Thank you so much for sharing your thoughts on the value that you find from the Healthy Skin Show, and I hope each and every one of you continues to find value, and if there is a particular topic that we have not covered yet here on the show, feel free, shoot us an email or connect with me over on Instagram and let me know what topics I should continue to cover on the show. Now, if this is, say, your first episode that you've ever heard of the Healthy Skin Show, I want to make sure to introduce you to Dr. Peter Leo. He's a clinical assistant professor of dermatology in pediatrics at Northwestern University, Feinberg School of Medicine. He received his medical degree from Harvard Medical School, completed his internship in pediatrics at Boston Children's Hospital, and his dermatology training at Harvard, where he served as chief resident in dermatology. While at Harvard, he received formal training in acupuncture, and he's written a textbook on integrative dermatology and has published over 100 papers. So now that we have all gotten to know one another, let's dive into today's conversation. Thank you so much, Dr. Leo, for coming back to the show. As always, you're one of my favorite guests, and I really appreciate you being here.
Oh, thank you for having me. It's always a pleasure.
Well, so today, I appreciate you being interested in answering my questions about this. Number one, today we're going to dive into the situation that I find a lot of clients and readers and listeners in, where, like, for example, I'm not a medical practitioner, but like there are times when a client will express to me that they're in a flare and they don't really want to go back and ask for help because they're afraid that the doctor is just going to give them steroids. But in the same regard, I'm hearing symptoms that sound like an actual infection. And I get concerned because, like, as you and I both know, because we've worked on some cases together, an infection can sometimes get really bad. And so it's important to get medical, to have somebody who has that medical background look at what's going on. And so there's confusion a lot of times about the type of testing that they've had done in the past versus what could be helpful now to help them identify what's actually causing the flare. And so I'm so glad that you wanted to talk about this. So we're going to be talking all about that today, different types of tests that you as a dermatologist can do and what's the difference between them, when can they be useful, and how especially sometimes you could get a particular type of test multiple times throughout the course of your journey because it might show different things, especially when it comes to like a skin infection. So anyway, what are your thoughts on that? Because I think a lot of times they think dermatologists don't do testing, but you do.
We definitely do, and I would say there are some things that we're really good at and some things that we're not so good at. One of, I think, the biggest unmet needs in our specialty overall is we need better, safer, long-term management for chronic conditions, right? Mm-hmm. That's why I think I send so many people to you. We need other ways to approach these things because sometimes we're like a one-hit wonder. We keep giving the same thing over and over. That being said, where we're really good is more acute things, right? Acute infections and complications like that. That's sometimes when you often want to go to a more general dermatologist who can really help us get to the bottom of that. And it's true, there's a number of different types of infections that affect skin conditions and can be secondary to them. And I love the way you put it. They can come up over and over again. So let's start with one near and dear to my heart, atopic dermatitis, right? Mm-hmm. Now, atopic dermatitis by itself is not an infection. We know that the microbiome is playing a huge role both in the gut and on the skin, but we wouldn't call it an infection by itself. That being said, because that skin barrier is so weak, many patients have recurrent Staph aureus infection of their skin and probably have dysbiosis, imbalance all over their body. But when it gets bad enough, if you don't treat it, you can get really sick. Mm-hmm. I always tell the story. I had a patient who was in the office waiting for me, and I was running a bit behind, as we're wont to do. And I finally came in the room, and the patient was on the bed, sort of listless. And I was talking to his mom, we're chatting for a while, and I kind of looked at my watch. I'm like, it's the middle of the afternoon. I'm like, is he always like this? And the mom said, no, he's been really like this just for the last couple of days. So I walked over to him, and I realized that he was quite sick. He was feverish. He was erythrodermic, red all over. And I picked him up and we actually walked him right to the ER. He had a blood infection. So he got infection through his skin, in his blood, sepsis. He was very sick. He needed several days of IV antibiotics in the hospital and then was okay and was able to complete it by oral, but really scary. So a bacterial infection through the skin can be potentially even life-threatening, even though it's quite rare. And of course, more localized infections like impetigo, or a smaller cellulitis, they really should be evaluated and treated.
This episode is brought to you by my line of professional grade supplements called NutriQuel. I crafted these supplements especially for those struggling with chronic skin rash issues and based the formulations on my extensive research and clinical experience in my private practice. They are made from the highest quality ingredients and tested to be free of different allergens so that you can support your gut, liver, and overall health with the formulas that I've found work best for my skin rash warrior clients without triggering a flare. I'm excited to share them with you, so check them out at quellshop.com and use the coupon code GET15OFF to get 15% off your first order. I'll put a link in the description below. And now let's jump back to the video. Yeah, and so in this particular instance, if let's just say, for example, you didn't think that the situation was that severe where you just were like ER time and they're in the office and they're, complaining of burning, hot, red, super itchy skin patches. I think a lot of times the confusion that at least I initially hear was, well, I had a biopsy 2 years ago and it didn't really tell me anything. So I don't see the point to going back now for this. And I'm like, well, no, what you want to try to get is like a culture where they're going to look to see what's there. So can you talk a little bit about the difference of what exactly is a culture and then what is a biopsy?
Perfect. That's a perfect opening. So what are some of the different techniques we can do? So a skin biopsy is, something that's great. A skin biopsy is where we numb up the skin and we either do what's called a shave type, we kind of scoop a little bit off with no stitch, or a punch type where we actually use a little instrument. It looks like a cookie cutter, a tiny cookie cutter, and we take a little plug of skin and then we usually put a stitch to close that up. Now, both of those are really important tests because sometimes patients or families will think, oh, is it going to go to some some lab and they do some kind of computerized analysis. No. It literally goes to a pathologist, right? Another doctor who is trained to look at skin samples, in this case, ideally a dermatopathologist, but there's other types of pathologists, general pathologists who can look at anything, GI pathologists who look at stuff from the gut, neuropathologists who look at brain tissue. There's really specialized. Sure. And they do specialized staining, and under the microscope, they are going to give an impression, a description of what they see. So a skin biopsy is really a powerful, it's not really a test, right? It's a diagnostic procedure that then, and sometimes we'll even have a discussion about it. The pathologist will call me and say, this is really interesting. I saw this kind of cell type under there, or the blood vessels look really strange, or what's going on? There's a lot of activity on the surface of the skin, and then we'll have a back and forth. So it's really important, and it helps us not only rule out some bad things, for example, certain types of cancers that can affect the skin, like cutaneous T-cell lymphoma, but it also can help us rule in things. They can say, there is a ton of little blisters. Are you sure this isn't a contact dermatitis? And sometimes I'll say, maybe we should test again, and do that. So that's a biopsy. Now, a biopsy can show signs of an infection too, but it's not very good at that, honestly, because signs of an infection from a biopsy standpoint really tend to just be a lot of inflammation. We're just seeing the body's response to it. Better for an infection, bacterial infection, is a swab culture. So we literally just take, a sterile Q-tip, essentially, just a cotton swab, and it's part of a little kit, and we literally just rub it on the area and pop it in a special kind of medium, and then that grows. So sometimes it's funny too, a patient will call me the next day and say, well, can you tell them to rush that culture? And they say, well, I could tell them, but we can't rush the bacteria, right? They literally put it on a plate and they let it wait, and we watch, and every day they look and see if something's growing. It sounds kind of crude, but it's a very functional kind of test. It's sort of old fashioned. Maybe in the future, we'll have some tricorder or some way to do genetic analysis immediately. But right now we literally grow it out. And when it grows, then they can run tests on the bacteria. So that's the best way to know not only what is the bacteria on your skin that's causing trouble, but also then they can do what's called sensitivities. They can tell me, hey, you know what? This bacteria is really nasty and it will not respond. We actually did a test and it doesn't respond at all to X, Y, and Z antibiotic. And that's really when people say MRSA, methicillin-resistant Staph aureus, that's literally what it means. When they put methicillin or its cousins, oxacillin, on it, it didn't respond to it. So they say this is a nasty bug. It didn't respond to a conventional antibiotic that should work. So don't use what you were going to use. Pick one of the other ones that will definitely respond. They can even tell us, they can show us the sensitivities and say it doesn't like this antibiotic, this kills it, so use that one. And that's so important. Now, there are some other tests we can do too. Very quickly, we can do fungal analysis. So sometimes a complicating issue is fungal infection. Mm-hmm. There can be yeast type overgrowth on the skin. Like if we think about tinea versicolor, right? The malassezia, it's all splotchy. That can be a complicator of eczema or its own condition. We can do a little thing called a KOH or potassium hydroxide preparation. I scrape very lightly. For kids, I say, I'm just going to brush the skin. It doesn't hurt. We kind of brush, take some of the flakes. I go right to the microscope, right around the corner, and I do a special stain on there. We use potassium hydroxide, hence its name, and then I wait for a minute and look under the microscope. So right there, I can tell you in 1 minute whether or not it's fungal infection. And that also works for ringworm of the body, or of the scalp, anywhere like that. We also can do a scabies prep, right? Sometimes people have scabies. Scabies are these little teeny tiny mites. They're invisible to the naked eye, but not to the microscope. So what we do is we'll scrape the little parts of the skin, or even better is we can scrape under your nails, because if you're itchy, you're kind of collecting little scabies mites under your fingernails. And then I just scrape underneath and I look under the microscope, and I'll often bring it in. I'll bring my camera in and I'll say, have a look at what we have. And they'll see the little tiny, they're bugs, they're little tiny bugs and they're on your skin. And that's all those things we just said, bacterial infection, fungal infection, scabies, are all super treatable, and we can usually treat them definitively. It's one of the few times we're kind of excited when that happens. We're like, we can help. This we can do. I can't cure eczema, sadly, but I can cure this darn, fungal infection, or I can get rid of scabies.
And we talked before a little bit about staph infections, and I did want to remind, I will link it up, that episode, in the show notes, but I wanted to remind people listening that it's not just staph, right? You could have a strep infection on the skin. You could have a Pseudomonas infection. I remember you specifically mentioned those two bacterial issues as well.
Absolutely. So staph is a big one that we deal with all the time, but there are dozens of different bacteria that can affect the skin. Pseudomonas is an important one because that's the one that causes hot tub folliculitis, where people will hang out in a hot tub over the weekend, maybe, at the gym or at a hotel, and then they get all these little pustules, and that's Pseudomonas usually. That one can cause that. Pseudomonas can also cause an infection underneath the nail we call green nail syndrome. So there's a number of different bacteria that can do it. Strep, we think of strep throat, but you can also get strep around the anal area and as a skin infection. It can happen anywhere on your skin, and there are many others. Sometimes it's more exotic, but no doubt that staph is the big one that we deal with on a day-to-day basis.
That's good to know, and I hope that everyone knows too, and I just want to emphasize this. If you, say, went a year ago and had one of these culture swabs done, but today you're having an issue, you can't refer back to that other culture. Like, it's a snapshot in time, correct?
Exactly. And you may have an infection once and then get you better, and then 6 months later have it again. So the biggest thing I think for bacterial infection is skin pain or tenderness. If it's just itchy, I'm not as worried. But if a patient calls me and says, it hurts, it's sore, then I'm like, whoa, that's a super, 4-alarm fire. We have to make sure, because that skin pain, while it can happen just from some conditions, eczema is known to have some pain, it is a pretty good indicator that there could at least be a chance of infection going on. And
can I ask you just one moment? You mentioned cellulitis before. Could you just talk to people about what that is? Because I think they may have heard the term in the past, maybe like an older relative had cellulitis, but I don't think many people actually understand what that is specifically.
Yes, so cellulitis refers to a superficial skin infection. So the most superficial of all is impetigo, right? That's where you get kind of just a scaly, scabby stuff on top. We often call it the honey-colored crusting. And that is so superficial, it really hasn't gone deep into the skin yet. But as you get a little bit further down, then we have what's called cellulitis, and that's usually it's sore, it's a red area of skin that's involved, it's tender to the touch. Of course, beyond that, it can actually get even deeper into the skin. We can have things like fasciitis, where it goes way down, and and so on and so forth. And of course, even cellulitis though can get into the blood, and that's a problem if it's in the blood.
So if you have any of these symptoms, this is where you really want to see your doctor. That's really important. That's not something that you're going to be like, oh, I'm just going to apply some like Manuka honey or put some aloe or I think I know that there are remedies out there for things, but I have worked with some clients who I would say just like really didn't want to go get help and waited a bit too long and ended up in really dire straits, like full body infections, which Dr. Leo and I have had conversations about because he also then ended up seeing them. And it was a pretty serious situation for a lot of individuals. And so we just want to impress upon you that it is important to get medical attention because it's not something not everybody ends up in the ER, but you don't want to end up in that boat. You definitely don't want to end up in that boat.
Exactly. That's the biggest thing. Because the infection can cause so much trouble and it can even be life-threatening, we really want to make sure we take care of that aspect. And that is something that can really be a true emergency if you have an infection of the skin.
Now, with Demodex mites, would that also be like a scraping as well?
Yes. Yeah. So that's great. So that's a little bit less commonly done, but absolutely. So those little guys, there's kind of two variants of the Demodex. They're called follicularis and brevis. The follicularis are a little longer. The brevis are little shorties. They're also microscopic. You can't see them with your naked eye, but we can actually scrape very gently, and then I smear them on a slide. Now for those, I don't use any stain. I just look right under the microscope, and it's so cool. They're still alive. So I actually have some videos. I'll show you one day. You see them kind of crawling around, and they're just kind of eating all the little sebum. They eat the sebum, so they live in our little pores. And then now they're a normal commensal, so they're on everybody's skin. But in certain conditions like rosacea, they seem to go crazy. And so there's even a condition called demodicosis where you just get an overgrowth of them. But we scrape, and all of a sudden you see like 5 or 10 of them around a follicle. You're like, oof, there's too many. And that is one of the things we can, again, treat pretty easily. We actually can use Well, one of the medicines is kind of now infamous because it's been discussed in terms of COVID, right?
Yes.
Ivermectin. So people take ivermectin, they've been talking about that as potentially a COVID treatment. I don't know really whether or not it helps. I guess there's some evidence that says maybe it helps a little bit, which is kind of interesting. But as a topical agent, it turns out that its main use is an antiparasitic. So it kills Demodex really great, which is neat. So we use it both in rosacea and in demodicosis, which is kind of neat.
Wow. Okay, so let's talk a little bit about like more allergy type testing. So there's patch testing versus the prick testing. And do you do that, or do you send someone to like an allergist? Because I do get questions about this, like who would actually do that type of testing?
Yes, and there's a lot of confusion around testing, but you're right. So there's at least two major types of testing. There is the testing that looks for IgE. So that would be the kind of allergies that make hives or hay fever or conjunctivitis. That is normally done in an allergist's office. And there's two ways to do it. There's prick testing, where they just kind of poke at your arm or poke at your back and then wait about 20 minutes or 30 minutes and see if you're getting hives. Or there's the blood testing for it, okay? They actually are looking at the IgE levels in the blood. They both have their pluses and minuses. Many allergists will do both and kind of correlate them. But generally speaking, those are looking at IgE type allergies, urticaria, hives, hay fever. There's a conflation and confusion because people say, well, how do you know what I'm allergic to for my eczema? Didn't that tell you? And it's like, well, not really. That would just tell you what you're getting hives to. Now, hives can be a trigger for eczema, but there's a whole different kind of testing that's usually not done by allergists. Some do it, but typically done by dermatologists. This is the type I do, and that's called patch testing. Now, patch testing is where you come in. It's much more involved, and instead of a 30-minute little thing, we actually put stickers on your back in these things called fin chambers. They're little tiny little metal discs, and they put a little the chemical underneath, and we put tape on your back. We usually do 80, and it's called the North American standard. So there's 80 different little circles on your back. You have to leave it on for 2 days. So because this is this is a T-cell mediated response. So we're actually looking to see we're not asking what makes you hive, because that's an interesting question, but really not so much related to eczema. We're now saying, what gives you eczema, right? It's the ultimate functional test, because then when we peel this off on Wednesday, we put it on Monday, we take it off on Wednesday, I literally am looking for eczema change. So I'm looking for that redness, the swelling, scaling. Sometimes it's so severe they get a blister, a big old blister where it was. And so this is your skin telling me very directly, hey, this one drives me crazy. This chemical, this cocamidol propylbutane in shampoo and soaps, this preservative is driving me nuts, this natural, coloring or whatever it may be, right? Or fragrance. We can find it, and then I can tell the patient, your skin really hated this. And again, it's awesome because I can show a picture of their back and they say, oh my goodness, what was that one? Okay, that one was, methylparabens. So we got to avoid it because your skin hates this. And even a tiny amount of exposure can drive this reaction.
Can I ask you, so with the patch testing, you said there's 80 little discs. So does it include like food products, or is there like if the patient seems to react to a particular shampoo or something like that, how do you determine what the 80 items are?
So great. So first of all, there are thousands of allergens to choose from. So you can pick thousands and thousands of them, like anything under the sun, including foods, and people do it. That gets a special name. It's called atopy patch testing, APT. And that's really interesting because it's not as approved, it's not as understood or approved or done as commonly, but some people are experimenting with it to actually put food products on the skin and see. It just seems to be a little bit less reliable because part of the issue with food is that it can be irritating in and of itself. So, if you put some tomato sauce on your arm, you might be reacting to tomato, but it's also acidic. Your skin's not designed for that. So this is the confusion. And truth is, this is a confusion about a lot of different things we test for. But over the years, people have refined it. So they find the perfect percentage, or they find an ideal, vehicle for it. Many of them are held up in Vaseline. Some of them need water, though. They can't be in a greasy thing. So there's all these little tricks and stuff that they've learned over the years. So these are a little bit more codified. That being said, there are some food products, and for example, balsam of Peru, it's a natural product, it's a plant product, and it's present in a lot of food. So if people are allergic to it, sometimes we say we need to go on a balsam of Peru free diet. Nickel is another thing. Nickel is very common, and for really severe nickel allergy, if we can't get it under control, unfortunately, you have to go on a low nickel diet. It's almost impossible to go nickel free because there's nickels in everything. It's in a lot of fruits and vegetables, right? But we can go on a low nickel diet, and I hate doing it because it's brutal. it's like no canned foods, so you can't eat spinach, so chocolate, all this stuff. But usually we don't have to. I will tell you one last story because I think this is neat. We had a patient who showed a really strong allergy to benzoyl peroxide. And I was like, because she didn't have acne, she wasn't using any benzoyl peroxide products. And I just didn't think much of it. You can react to things you're not really seeing. Maybe it was from years ago or something. I didn't think too much of it, but she had terrible lip dermatitis and we couldn't get it under control. Finally, a friend of mine told me, they bleach flour with benzoyl peroxide sometimes. And I was like, that's kind of interesting. I didn't know that. And I asked the patient about flour, and she said, oh my God, you're not going to believe this. Every morning I go to my favorite bakery and I get some kind of a pastry and they have flour on top. So she switched the pastry. She was still eating flour, baked flour, but it was the raw flour on top, where they sprinkled it.
Sure.
She switched her pastries, lips cleared. So we knew it. It took me months because I didn't make the connection between benzoyl peroxide bleaching. The whole thing is crazy. And I've only seen that one time, but now I remember that because that was a time where right? Isn't that a wild story?
Well, now your friend told you this and you've now shared it. So now everyone will know that benzoyl peroxide is used to help bleach flour. I did not know that. That is wild. Wow. My goodness. Can I just ask real quick, cobalamin, that's also one of the, I guess, metals that you test or the substances?
So cobalamin is vitamin B12, but cobalt is the
I'm sorry. Cobalt. I meant cobalt.
Cobalt and nickel often run together. Absolutely true. And cobalt is used in some different industrial processes too. So yeah, we'll often see that overlap for sure.
And for somebody who has a cobalt allergy, it's always been confusing for them, and actually for me as well. Do you recommend they avoid B12 supplements as a result of that?
Typically, I don't. Yeah, I think they're distant enough that I'm not too worried that there's a connection, honest to goodness. So yeah, I've not seen that come up, for a patient that's clinically relevant.
Okay, that's helpful. That's helpful for people to know, to maybe feel okay, just testing it out and seeing how they do, because it is confusing. There's so many things that can cause issues, and it's good to know that there are other tests that you can ask for, or that you could have a conversation with your dermatologist or, like you said, an allergist about, to see what's going on, to figure out, is it a potential exposure that could be one of the factors. I recently had a client, she loved this natural deodorant, and it ended up she was allergic to something in the deodorant. It was a very ubiquitous natural product that's used in a lot of things, and she's like, I can't use this, I actually am allergic to it. And since she's reduced that exposure, she hasn't had as severe of rashes in obviously the armpit area. So that's a good thing. But thank you so much for clarifying all of this. I know everybody listening, as always, you've got I think the top listened to podcast episodes on the Healthy Skin Show, and we'll add this to the pile because I know that you're just so generous with your time and your wisdom and helping to educate the patients so they can ask better questions and have more educated conversations with their doctors. And I think that is so important, especially when you've spent years suffering from something, to be able to ask the right questions or ask about tests and whatnot. It's a part of the journey. It's a part of advocating for yourself.
I couldn't agree more. Well, it's always so fun to be here, and I really do hope it helps some people, even just giving some hope or some new ideas, and helps that discussion, because it is complicated, and every little bit of knowledge, I think, can bring us closer to finding some relief. Absolutely. And so for anybody who is looking for a dermatologist, you can check out Dr. Leo. He is in the Chicago area. I'm going to put all of his links and everything into the show notes for this episode. And thank you so much, Dr. Leo. I really appreciate your time. Thank you for having me. I'll see you soon. I feel like this topic was extremely important to share with you all because the type of testing that dermatologists do tends to get mixed up in the minds of clients and listeners and readers on my newsletter and on Instagram. And I thought, why not provide you all with some sort of clear
tutorial, so to speak. So that way you understand the difference and why having a biopsy, say 2-3 years ago, isn't really all that helpful if now all of a sudden you're flaring and it could possibly be an infection. And that's why a lot of times I'll suggest to clients, hey, I think you might need to go get a culture. And they're like, yeah, but my biopsy said, and I'm like, that's different. And that was a long time ago. So it's really important to understand the difference so that you can better advocate for yourself and know what you could potentially ask for when you go to the doctors. If you're looking for resources, links, or show notes, or you'd like to leave a question or comment about this episode, head on over to skinterrupt.com/246. That way we can keep the conversation going. And if you found the Healthy Skin Show, and in particular this episode, helpful or illuminating, please make a point to share this with someone you know who might appreciate being clued in on this as well. And then head over to your podcast platform of choice, rate and review the Healthy Skin Show, and then hit the subscribe button. That way you never miss a weekly dose of all of the different research, tips, strategies, and knowledgeable nuggets like this that could help you advocate for yourself and get you on the road to rebuilding healthy skin. Thank you so much for tuning in, and I look forward to seeing you in the next episode.